Hello guys, with you today, Dr. Muhammad Hamid, an ECVMG certified physician, and we are going to go today through a lot of high yield stuff for the USMLE Step 1 exam. So, first, we may start talking about the myocardial infarction, the complications of myocardial infarction. So, the different kind of complications for myocardial infarction, and you have to know that they are kind of subdivided according to the time frame. So, the time frame of the complication is very high yield for you to know. First is a cardiac arrhythmia. You know that the cardiac arrhythmia doesn't have any specific time to occur. It may happen in the first few days and even in the first hour of the MI, and the patient may have lethal arrhythmia and is gonna die. From the first few days, and it may continue to occur even several months after the MI. So this is for the cardiac arrhythmia, and for the types of it may be supraventricular, ventricular, or conduction block according to the specific area insulted by myocardial infarction. And this occurs on the cellular level due to myocardial death and scarring, and they are very, very important causes of death before even reaching the hospital, and in the first 48 hours for after post MI. So this is for the cardiac arrhythmia. The second complication is peri-infarction pericarditis. You know that different kind of pericarditis that may occur after MI, that occur after 1 to 3 days. You need only one day to pass, and for this to occur is called peri-infarction pericarditis. From its name, it is occurring after MI, immediately after 1 day, peri-infarction pericarditis. The other kind of pericarditis is called the post-cardiac injury syndrome. Post-cardiac injury syndrome equals fibrinous pericarditis. It's more famous for fibrinous pericarditis. It occurs weeks to several months after MI. Post-cardiac injury syndrome or fibrinous pericarditis occurs weeks to several months after MI versus peri-infarction pericarditis 1 to 3 days. On examination, the usual stuff for pericarditis, the history, pruritic chest pain, that means that increases with breath, and all of the stuff for pericarditis. And by auscultation, you will find pericardial friction rub, and the ECG, you will find the ECG changes, you remember them, which includes the widespread ST elevation. You know, for MI, you will find ST elevation in the inferior lead or in the anterior lead, but if you find ST elevation which is consistent through different kind of leads, this indicates pericarditis. So widespread ST elevation and PR depression, and by echo you will find a small pericardial effusion, and this is kind of benign relative to the cardiac arrhythmia and usually self-limited. This is for the peri-infarction pericarditis. And the next, these are two complications which are more alike, grouped together from the second to the seventh day. From the third to fifth day, you have 2 or 3 days for this to occur, which is the rupture. The different parts of the heart that is gonna rupture. The papillary muscle is gonna rupture. The interventricular septum is gonna rupture also. So for the papillary muscle rupture, the effects of them both are the same. So if the papillary muscle rupture or the interventricular septum rupture, you may have cardiogenic shock, which due to decrease in the perfusion of the organs. So this is for the cardiogenic shock, and the back pressure of the blood to the lung causes severe pulmonary edema. So you have cardiogenic shock and severe pulmonary edema. Here again also you will have cardiogenic shock and severe pulmonary edema. So this is for the effect of both of them. An important hint for the papillary muscle rupture, it is kind of subdivided into the posteromedial and the anterolateral papillary muscles. The posteromedial one has a single blood supply coming from the posterior descending artery, where the anterolateral has a dual blood supply from the left anterior descending and the left circumflex artery. The posteromedial is more vulnerable. Single blood supply from the posterior descending artery versus the anterolateral papillary muscle is vulnerable. Dual blood supply from the left anterior descending and the left circumflex artery. And the next is the interventricular septum. The effect is the same, cardiogenic shock. The blood is not perfusing well the different kind of organs, and the back pressure causing pulmonary edema. And on a cellular level, this is caused by a macrophage mediated degradation. The macrophage mediated degradation is the cause on a histological level, causes something like artificial VSD. You are after MI and the septum rupture, you are causing an artificial VSD or a ventricular septal defect. And you know that the pressure is more high on the left side. You are creating a left to right shunt. So the blood is going from the left side, from the left ventricle into the right ventricle, and consequently the oxygen will increase and the pressure will build up on the right ventricle. Again, the next complication is the ventricular pseudoaneurysm. Also, this occurs after 3 days and may continue for 2 weeks. So the symptoms kind of non-specific. All the symptoms: chest pain, murmur, arrhythmia, syncope, heart failure, and may even an embolus may form embolus from a mural thrombus. And the ventricular pseudoaneurysm is kind of weak. That does not contain all the layers of the heart. So this is why called the pseudoaneurysm. But if so, it may rupture and cause cardiac tamponade and death. So a free wall rupture contained by adherent pericardium or scar tissue, and does not contain endocardium or myocardium, as we have talked about that. So adherent pericardium, adherent scar tissue, no endocardium, no myocardium. So not the normal kind of distribution of the layers of the heart. So this makes it more likely to rupture than the true aneurysm. Next complication, after the patient has had MI and he passed 5 days, 5 days from MI, the patient here in this stage is vulnerable to ventricular free wall rupture. So if the free wall ruptures, you are putting the patient in, again cardiac tamponade, and the leads to sudden death. So acute form leads sudden death. You may have the patient with a pericardial effusion that is very big, and the patient is adapted to that. So this is because the rate of formation of the effusion is gradual. So you're giving the heart the chance to accommodate this fluid. So but here you have sudden free wall rupture, sudden buildup of the fluid, and so most commonly sudden death. So you may have some conditions that may protect against free wall rupture if the patient has hypertensive cardiomyopathy and LV hypertrophy, or a previous MI that caused a scar. So these are kind of bad problems for the patient, but they are protective against ventricular free wall rupture. Left ventricular hypertrophy and previous MI are protective against the ventricular free wall rupture. So for the true ventricular aneurysm, you remember that in ventricular pseudoaneurysm, you need only 3 days for a ventricular pseudoaneurysm to form, but for a true ventricular aneurysm, 2 weeks and above, and even several months, but associated with fibrosis and dyskinesia of the heart. So the last most important, very important complication is the post-cardiac injury syndrome, other famous name for it, fibrinous pericarditis. So you have to know that the mechanism of it is an autoimmune reaction. So the third name for it is the Dressler syndrome. The Dressler syndrome, synonymous for fibrinous pericarditis or autoimmune pericarditis or post-cardiac injury syndrome, different kind of names for the same problem. So the cardiac antigen which are released after the injury it may form antibodies, and the immune complexes deposit in the pericardium. So this may cause kind of inflammation. So this is an autoimmune condition. This is all for the cardiac complications, or of all the complication after myocardial infarction. So for the treatment of acute coronary syndromes, it's subdivided into unstable angina and non-STEMI. They both have the same treatment, and the STEMI, which have the same treatment in addition to BCI, as we are going to talk about that. So for unstable angina and non-STEMI, first you have to give the patient anticoagulation, example heparin. This is anticoagulation plus the famous antiplatelet therapy, dual antiplatelet therapy. It is aspirin first, and the ADP receptor inhibitor clopidogrel. So this is dual antiplatelet therapy, anticoagulation plus dual antiplatelet therapy, and you stabilize the patient. You may give beta blocker, ACE inhibitor, and the statins. So these are very beneficial for the patient with unstable angina. You have to memorize the regimen: anticoagulation, dual antiplatelet therapy, beta blocker, and ACE inhibitor, and the statins. And this is a main control regimen. But for the symptom control, you may give nitroglycerin and morphine. This is based on the symptoms of the patient, not for the rigid control therapy or the regimen. So for the STEMI, you may give the above medication, and you have to reperfuse the injury. STEMI means ST elevation myocardial infarction. There is a transmural infarction of the cardiac muscles, and so you have to reperfuse the organ, or the cells are gonna die. So the reperfusion therapy, you may do a percutaneous coronary intervention, or BCI abbreviation for percutaneous coronary intervention. You are going through percutaneous and giving you take a vascular access to go through the heart and put a stent. This is called the percutaneous coronary intervention. It is preferred over fibrinolysis using streptokinase, for example. So but if BCI is not available, you may go and give streptokinase. This is for STEMI. And if the right ventricle is affected, example for the RCA occlusion, right coronary artery occlusion, so this in a specific situation, you may give you know that fluid is famously knows that you don't have to give or you shouldn't give the patient who's going to STEMI or angina fluids. It's very dangerous, but this is a very high yield point in RCA occlusion. RCA means that the right ventricle is affected. RCA, right coronary artery, is perfusing the right ventricle. Right ventricle is affected, so the right ventricle is preload dependent. So you giving IV fluid to increase the preload and increase the for starting mechanisms that you put so much fluid or gives us the amount of fluid needed so for the heart muscle to contract. So you'd also you have not to give the patient you must not give the patient nitroglycerin, contraindicated in this condition in the RV right ventricle infarction. So the next topic here is cardiomyopathy. So you know